In recent times, the world has faced unprecedented challenges posed by infectious diseases. The recent global pandemic has underscored the critical role of innovation and technology in diagnostics to manage infectious diseases. So, I bring to you our third topic of the day, exploring advanced approaches in diagnosing infectious diseases, unveiling innovations and best pathology practices. Now, I'd like to call upon stage the speakers for this panel. Dr. Nena Ingole, Laboratory Director, Molecular Diagnostics and Reference Laboratory, Kasturba Hospital for Infectious Diseases, and Additional Part Professor, TNMC and Nair Charitable Hospital, Mumbai, India. Welcome, ma'am. Mr. Ankush Gupta, Chief Executive Officer, Sterling Accurate Diagnostics. Sir, I'd like to have you on stage. Mr. Bhaumik H. Trivedi, Clinical and Diagnostics, Shimadzu Analytical Private Limited. Mr. Bhivash Chakrabarti, Head, Regulatory, Quality and Government Affairs, South Asia at BioMiru, India Private Limited. Dr. Ravi Gaur, Chairman, Medical Advisory Committee, Unipath Specialty Laboratory, Founder and Director, DRG Path Labs. Dr. Gaur will be leading this panel discussion as the session moderator. Over to you, Dr. Gaur.
Well, good afternoon, everyone. And I'm sure this is lunchtime, and we never had a tea break. It's a marathon session. So I won't keep you waiting much, proper thing. But very important to, talk about something. What we're talking today is exploring advancement in diagnosing infectious disease. Now, infections, actually, all of us have seen that. The importance. Probably we have forgotten about infectious diseases pre-COVID. It was like, okay, good, healthy lifestyle. We never talked about infections. But I think COVID reminded us infections exist, and we need to really work on it. We are working on very advancements, cancer, lifestyle disorders, and we felt that, okay, good hygiene, good practices, everything exists. But when the COVID came, we realized that we are miserably left behind. So we have not really worked on infectious disease. Pathology, yes, a lot, but I think microbiology, a lot has been done, but it has not been actually used in the practical aspects. So that's something we were talking about today. It's my pleasure to have, I welcome all the panelists right here. I probably say, let's diagnose to defeat. And that's the panel we're talking about, unveiling a path to a healthier world. In the field of diagnostic today, we have witnessed remarkable transformation. We have started manual, automation to robotics. That's exactly what's happening in the microbiology or infectious disease segment too. It's a continuous learning culture, basically. It's just not an asset probably, and that's become a necessity today. So, and in infectious disease, more you know about it, more you know about the strains and substrains and substrains and sensibilities, more detail you know about it, its knowledge becomes is more powerful. You have to know much more about everything. And they do pose a lot of challenges. I think we have seen that. The way COVID was there, I think rampant, but the way we came back, we geared ourselves well, we treated, and we have overcome it. So I think it's a big challenge. So I think today the session will like to uncover, discover, innovate, what all things are there. We have discussed, somebody talking about precision diagnostics, the turnaround time, various sample types, and all this is actually very, very important today when we talk about the infectious disease. I'd like to focus on the infectious disease only, and I think move on. I think we have two other panelists are not here, so I think probably you'll be able to finish in time before you feel hunger pains for the lunch. So my first question, I think I straight away move to Dr. Nena Ingole. Dr. Ingole, you're seeing that what are the challenges in identifying and characterizing pathogens? especially in the context of emerging infectious disease and AMR. I think that's the thing. What are the basic challenges you face, and when you see the AMR, can you just share your wisdom?
So before going, I'm from an academic background and a public health background. So I think a little different from the industry perspective. Let us understand first what we mean by emerging diseases and MR. When we say emerging diseases, we always think of nowadays of COVID pandemic, as Sir rightly said. But when we say emerging diseases, it is any new pathogen which comes up, or any pathogen basically which is increasing in number, or the same pathogen which is presenting have a new, maybe higher virulence, higher resistance, or maybe some new characteristics. And that is why the role of AMR also comes in, because when we are looking at, we may land up in a situation where we don't have any antimicrobials to treat. We have tuberculosis resistance cropping up, we have antibacterial, and even nowadays Candida auris resistance we're looking at, even Plasmodium falciparum resistance we're looking at. So looking at a lot of, so what are the challenges when we look at it? When we're trying to do a surveillance for all these activities basically, is that first whether we have the awareness and I think the training capacity, and whether people are aware as to what is happening, and whether they are inclined to report whatever they are observing. I think that human resource, I think, plays an important role. Second thing, if you look at the pathogen itself, we don't know what pathogen can come new or what changes it can happen. Like it had happened with Omicron when it first came in. There are very diagnostic kits which could not detect the S gene. So even if the change in the, even the virus was the same, but because of the change in the characteristics, there were test failures which were happening. Now we don't know the host interaction, so that again remains a challenge. Many of our laboratories are not geared up, because for any new pathogen which comes up, what we need is basically maybe metagenomics or sequencing, which we still don't have facilities about. And even a rapid test, nowadays we have molecular tests established across, but any new pathogen comes up, whether we have those kits available with the required sensitivity and specificity and at the right time. And I think the most important when we talk of any surveillance challenge would be the reporting, data reporting. We don't have ideal platforms available, and even if we do have the platform available, there's a lot of hesitancies among the people to report it. Maybe they don't want to share the data, they don't have the motivation to share it, and many times what they report is only the positive cases, increasing or the positivity, because the denominator, because 2 out of 200 and 2 out of 2000, there's a way different interpretation what you're looking at. So when we overall look at it, we have a lot of challenges, I think, when you look at, and of course resources, I think you cannot forget the resources. So there are challenges when we're trying to control, and I think that is what we have to look forward to.
I think, yes, I think very rightly said, challenges exist. And the biggest challenge today, the way I feel the rapid changes in technology is happening. You validate a technology today, by 6 months, you're getting to launch it out, something else comes up. I think, and same is happening with the pathogens and the viruses. You get ready for one, they change the strain, they mutate, and something else comes up. I think we need to gear up for that, probably one of the biggest challenges. I'll come back to you on the next question shortly, but my next question basically is Bhomik, you're here. Thank you for being here. I think I'd like to understand from you, what are the strategies for overcoming limitations in current diagnostic methods? Because there are challenges, but why can't we really, fight with them? What are the strategies? What are the basic challenges you feel in the current diagnostic? What are the limitations basically for that matter? And then, of course, how do you like to overcome? We'll have the next round. Bhomik, please.
Yeah. So limitations, maybe it will start with something fundamental. That is, when we're talking about the infectious disease, it's from the handling of sample, the integrity of it, because we have to also make sure that it becomes a point where it should not be virulent at a level where it will infect a lot of people as well. So it's from the handling. We have seen there have been cases where there were concerns with respect to biosafety and biosecurity itself, and it was leading to a scene where it was leading to multiple cases of infection from the source of collection itself. So it may start from that. So that is one of the limitations which I'm looking at. At the same time, we had seen in COVID cases itself, we were identifying COVID cases, but there had been multiple cases where we were unable to understand the severity of the infection itself. For example, people knew that the degraded nucleosomes or the ribosomes were one of the biomarkers which were being identified, which can really help us in understanding that what can be the severity of that infection of COVID-19, but it was never been focused. Without understanding the medications were being administered, we had seen the side effects of it. So probably understanding the severity of the infection and then understanding the therapeutic level of the drugs to be administered to the patient, by which we are not really affecting their health because of the post-infection symptoms, because of the medication which may arise. It is very much important to understand the therapeutic levels which should be administered to an individual who is infected. So I think these two are some of the major limitations which I'm looking at when we are seeing the infectious disease management. And third thing which I will also like to mention is, we are looking at genomics, we are looking at sequencing, but at a preliminary stage. For example, in case of tuberculosis by itself, if we see, we are jumping on to some high-end technologies without screening the biomarker by itself. For example, the tuberculosteric acid by itself is a biomarker, and mass spectrometers have been utilized to identify those biomarkers, which can be easily be done using sputum itself. So some preliminary screening is needed to be done when it comes to such kind of disease management is concerned. So I feel these are some of the limitations which I'm looking at.
Great, I think, yes, or you actually listed almost all things, but I think we are all here to overcome the limitations, and I think we have probably our next speaker probably, and I can see a couple of people sitting in the crowd. We have Gaurav right here who's talking about overcome the limitation, but in any case, we'll come back. But I think just one limit question. You talk about severity. For my interest, does AI can help in that?
Oh yes, I think that is a very favorite topic of a lot of people. In fact, it's even my personal favorite. I have been speaking about utilization of AI in a couple of forums in past as well. AI is doing magic. Obviously, if it has to be validated correctly, and when we are talking about patient care, we should not neglect the compliance as well when we talk about AI. Yes, when we are talking about severity in specific, yes, we need to work interdisciplinary. That is what I believe. Because when we are looking to do patient care, and when we are keeping the patient in the center, we need to see from multiple perspectives. Like for example, in a lab or in a hospital, when we are getting the biomarkers getting screened, we are getting the images, we are getting the X-rays, for example, in case of tuberculosis. Let's take that as one of the example. So we are screening tuberculosteric acid. We are doing some sputum test additional to that. We are doing some cultures. We are also doing the X-rays. So with the help of this, in fact, even in case of imaging, there are advancements which are happening. The patches itself which are being identified, the designs can be identified to conclude whether it is an individual is affected or not. So when we are talking about these prospects, there should be interdisciplinary approach wherein all these reports should be pooled at a center point. There should be by machine learning itself, it should able to understand the pattern of the infection, the level of it, and it should bring to an interpretation, which will help in solving the problems much faster, and will really help in managing a lot of patient care by itself. And in addition to that, when we're talking about infection by itself, point of care testing is something which is booming up. Now, these technologies are as small as your mobile device, and because of the 5G...
We're going to interrupt here, but we'll just come back to point of care once again.
Okay.
I was like, more like, we have, that's something next round or round.
Absolutely.
So I was talking like, for when you said about AI, and that's, I think, field is very, very interesting, because now AI entering microbiology.
Yes.
And probably, the day I get and now we're talking about point of care, I'm sure Vivas will also talk about something on similar part. So we got a rapid testing, better turnaround time. So within a day, today you admitted, by evening you have an entire panel with you. So I know how many days I'm going to stay in ICU. What going to my bill? Probably we're looking for that, maybe like that.
Yes.
Because that will help us to understand and navigate these challenges of expenses and the unpredictability, and when I'm going to go well, how long I will take antibiotics and develop AMR. I think AI will play a definite role in that. We'll probably discuss that at the dumpstone.
Absolutely.
Vibhas, I'll come to you straight away, because we have a important topic to discuss today. he talked about the challenges, he talked about limitation, using, but what are the newer technologies? Because innovation is happening at a faster pace, and you are the helm of affairs. And what are the newer advancement technologies when you're talking about cutting edge technology like NGS, PCR, CRISPR, so many things we keep hearing. By the time you understand register CRISPR, something else comes up. By the time I registered NGS, PCR, NGS came up. So I think your views on it. I think you're expert. Let me hear from you.
Right. So good afternoon, everyone. And I would like to thank the organizer, Voice of Healthcare, and Dr. Ravi Gaur. And for me, although the Voice of Healthcare is a second edition, but for me, it's the first time I'm coming to this forum. And coming to these infectious diseases and the technologies, before that, I'd like to update that pre-COVID and post-COVID. So pre-COVID, the molecular diagnostic was restricted to the premier hospitals and institutions, and it had a lot of limitations on the technology, on the various panels and equipments, and so on and so forth, the technologies, and it was only restricted to few diseases. Now, what has happened during COVID is that overnight, there were more than 3,000 or 4,000 labs are having RT-PCR machine. And all these labs are also got the NABL accreditation for doing this RT-PCR test, COVID testing. So RT-PCR is now known by everyone in the country. So it's no more a buzzword. And second thing is the labs which were not having the accreditation or the good management system has got the NABL accreditation. Second, there are technologies which now no more require the clean labs or series of labs with negative positive pressure. Now, these are small footprints of instruments, does not require for sample preparation, sample separation or anything. You just take the sample, put into the systems, and everything is been done within 1 hour. And not only does one analyte, it does multiple array of analytes, let's say 20, 25, 30, including bacteria, viruses, fungi, and it's called syndromic testing. So syndromic testing means that if you have respiratory illness, it can be any viruses, bacteria, or mutant gene, or antimicrobial resistant gene. And when these patients are in critical phases, their patients is in ICU, NICU, for example, pneumonia, is a disease where you need to have the diagnostics and the treatment at the same time. Otherwise, you lose the patients. And for pneumonia, the samples are very precious, and you cannot do hit and trial by doing this test, that test, series of tests, and you lose patients, and at the same time, the doctor will give the high-end antibiotics. So by doing syndromic testing, you know within 1 hour that what is the exact organisms, and you give the treatment. Similarly, it is there for meningitis, encephalitis panel. Then there are panels which are there for joint infection panel, gastrointestinal panel. So what has happened in last 5 years is that molecular testing is now no more restricted to only premier institute. It is now been done by most of the hospitals and labs. And now it has been closer to the clinicians. So microbiologists and the pathologists are now closely working with the clinicians. It is not that the reports are being sent and it's not been interpreted. So now the clinicians get in touch with the lab microbiologist, and they do the treatment based on the diagnosis. So diagnostics post-COVID has been in the center stage. So IBD is going to have the lot of game changer in the healthcare industry. And at the same time, it has been felt by the government of India. So there is a initiative called IPHL, Indian Public Health Laboratory. And recently I was in Hyderabad and I went to the Telangana State Medical. And I was surprised to see that they do 134 tests, the basic tests and the high-end molecular diagnostic test free of charge. And they have got end-to-end system. They have got ASHA workers who go into each villages, talukas, they get the samples. Then it been transported in the cold chain. It comes to the labs and then it has been done. The labs are run by 24/7. Then the reports are being sent over the mobile phone. The report goes to the clinician's desktop, and then if any abnormality is there and the patient is not coming, then they've been tracked. And then they can get the district-wise what are the trends of the disease. And what they said is that by doing this, they can reduce ultimately the cost of the healthcare. So if any district has got a cancer abnormalities, then they can take the decision. Then they can take the decision on the hemoglobinopathy. So various things. So what has changed is now the diagnostics it's no more a lab test. It is now been used by the doctors and for various decision making. For example, antimicrobial resistance is no more a buzzword. It's now being felt by not only the microbiologist, but everyone. But in India, it's still a long way to go because of different things, because of the regulation, availability of the antibiotics over the counter in chemist shops. And also, it is now the infectious diseases is now going to be here because it's not that the infectious disease has got any boundaries. So there are more infectious diseases are going to emerge, but what is important is that now there are various point of care testings and molecular diagnostic testings has now become more easy than before.
Thank you. That's something very interesting because that means like we are now, near patient, near doctor, near clinic. And a POCT coming up, I think we know certain instrument like BioFire, we have almost like a point of care testing. We get reports within 2 hours and multiple. I think more important is equally important will be multiple sample types and a turnaround time. That's something which is, I feel is a changing thought which is going ahead. So I think, I'll come to Bhomik, I think, for your, this question. Now, when there's so much of infection is happening, new technologies are being detecting kind of a thing. So how do you keep, the lab personnel safe from them? That's very important because do you think they require constant monitoring, testing, at the kind of biometrics we enter, inhalers? What is the best way? Because we have a little short time, but a little short. Can you just brief it up?
Yes. So quickly, I'll just touch the point. I mentioned previously as well the biosafety and biosecurity. Something is really very thing to be focused when we are talking about infectious panels and infectious testing. So the best way of doing and maintaining the biosafety levels in the lab is certainly the continuous education which needs to be done, because somebody mentioned in the previous sessions as well that the technicians, when they are in their universities or in their colleges, they're not being trained to the level at which they are supposed to work in the industry. So I think that is one of the way where the industrial community, from industry, we should come together and try to train the technicians that how they should manage it. At the same time, the engineering facility, the infrastructure which has been made up in the lab will really contribute a lot, because though we are saying that there have been labs which are free from those negative and positive pressures, but there are certain concerns which are still getting arise. So these restrictions are bound, and we need to follow that, because again, in past session somebody mentioned that if something goes wrong and if the biosafety levels are not being maintained, it's not the technician, it's not a doctor, but the founder of the organization is something who gets prison for 5 years, and that is the norm which India is following. So yes, we need to focus on this. So education is one of the important factor, and the engineering setup of the lab is also another important factor which I'm looking at.
And I think I can see, breath air coming in. Because, just, like, whether it's a lab or hospitals or a community or malls, probably you enter, breath, and you'll probably have analyzed the bacterial flora, whatever it is, exactly. Or how severity, your AI will help out in the severity too. And of course, brings to the next question to Dr. Munir. For that matter.
Just this
the next question,
because
when we talk about infectious disease, we're talking about the surveillance actually. Yeah. Surveillance is very, very important, and so we are all seen. Moment it's an infection, we feel about, I'll get infected, community get infected. So I think how important is the role of surveillance, and how to build up collaboration, and especially early detection, and of course I think the way the world is becoming global. So I'd like to have your views on this, and you can answer whatever you're adding to, please.
Okay. I just want to add a point to Dr. Bhaumik said. It's also important when you're talking of biosafety, biosecurity to know what level of organisms you're talking about. So because that risk assessment also I think is very important, because that is where the engineering structure would come to. Now coming to the question which has been put to me, there are two parts. I'll go for the surveillance importance first, just for the interns and etc. here. But when we mean by surveillance, the definition itself says it is data collection, analysis, interpretation, dissemination for public health intervention with the ultimate goal of disease control and prevention. So when we talk of surveillance, you have to monitor the diseases so we know what is happening, how the diseases are spreading, which area they are spreading. So we can have an early detection of the diseases, early reporting of the diseases, so that we can have good interpretation, intervention, so that it doesn't disseminate too far and we can control it fast. Now for this, when we're looking at surveillance, we have to have certain strategies in place. And I think that is where we lack today, because there's a lot of intersectoral collaboration which would be required. And right now, I think there's a big divide between the industry, the private sector, the public sector, and between the different policies what we have. So first we need a uniform platform or strategy on which we are all going to work together. And for that, another thing what we need is basically the common SOPs, or the practices which are going to be followed, because even the kits what we use, we know that they have all different sensitivity, specificity. I'm reporting a test with say IgM or IgT test, somebody is reporting with an antigen, PCR test, obviously there will be going to be differences. So when we are talking of any surveillance, first there has to be uniformity in reporting, there's a uniformity in the standardization of the SOPs that we are going to use, and then we talk of the training and capacity building. Because unless and until people are aware, as I said earlier also, they are not going to report any of the diseases, and we are again going to land up even whatever beautiful platforms we have for that. And obviously public-private partnership, intersectoral collaboration, these two also play a major role in dividing. Now we have a lot of surveillance going on, which can be any active surveillance, passive surveillance. We also have disease surveillance, like we have an influenza surveillance program which is run by the WHO. And we also have sentinel surveillance like what we do for our HIV. But I think what we have basically is more of a passive in our country right now, and which has to go on an active mode. And many times we are not reporting, I think, and that's where I think we have to really work on. But I think COVID has taught us, because whenever the ICMR portal was there, we have got used to reporting all the testing that we're doing. So I think if we take the same thing forward, I think it can help us to build those strategies, and I think it will help us to achieve that reporting and identifying the disease early, so that it doesn't spread and we can control it faster. Thank you so much.
I think that's something what we've done in COVID should continue at probably the bigger pace, better analyze. Vibhas, just quick question. We have just a couple of minutes left. Right. Because you're into the manufacturing also. What we're talking about, we talk about breath air. You think more POCTs or more are coming, and something in your update, what's happening on the early diagnosis and many sample type?
Okay. So POCT is going to stay. POCT is also one of the need, because when a patient comes to a physician, and it's more popular in US, which is called physician office lab, and the doctor do the diagnosis on the clinic itself and give the treatment. But except in India, POCT, except some rapid test, is not that popular, because first of all, the doctors themselves do not do the tests because of several regulations. But POCT, as such, there are many devices are coming which are closer to the patients, and it is that patient need not have to wait for 1 day or 24 hours or 48 hours. They can get the first-hand information at least as soon as 1 hour, 2 hours, within 2 hours. Now, for example, there are molecular devices. For example, Spotfire. A patient comes to a clinic for a respiratory illness and being diagnosed in 15 minutes for a RSV. So, which is a game changer. Because you have seen that the journey of COVID, there are so many mutations are there. And we do not know that which is the causative agent and how it done. Now, POCT for a pediatrician to do a test in 15 minutes and give the result, and the charges which is not covered by the insurance is going to be acceptable by the patient, yes or no?
No.
Because if you see the cost of diagnosis in a hospital vis-a-vis the cost of the length of stay, the cost of the high-end antibiotics, if you do a diagnosis, because in India, the insurance penetration is still not at very high, and the out-of-pocket expenses still more than 60% today. So the cost of treatment and the cost of antibiotics, the length of stay, vis-a-vis the diagnosis at the need of the hour, and the targeted treatment is more important than the diagnostics cost itself by itself. So I think this is changing. The clinicians are also getting more aware, and they are more demanding, and they are also now asking for the report and the feedback from the microbiologist, from the pathologist. So it's a good time that the clinicians are also getting the interest, and the new age clinicians, and because of the awareness, because of the internet, and because of the post-COVID awareness, the things has really changed. Now the lab and the clinicians are working very closely, which is a really good sign.
That's nice to know. I think the POCT has arrived. I think the more microbiology, the pathogens are arriving, the more the armed we are going to be. I think in the that's it. Probably we have a time's up is already written out here, but I will take 5 minutes before I sum it up, because very important. I feel that I started with when it comes to infectious disease, knowledge is the power. So I go to change the text instead of asking the audience. I can see someone sitting in the audience who was actually talking about the investment, bringing the pricing down, how you turn around, how you make the test happen, at the rural or the point of contact. That's right, So I think Gaurav, can you just share 2 minutes? I think you can have just 2 minutes, probably. Because he's doing phenomenal work in tuberculosis and maybe some in the infectious disease. I'd just like 2 minutes of yours. That's it.
Absolutely. Dr. Gaur, thank you for giving me this opportunity. A fantastic talk with the panel here. I think we are just starting up with our work in genomics. So Haystack, my company, is working in genomics and focusing on infectious diagnostics. What we are seeing today, the problems that you mentioned, Dr. Nana, the infections is a very wide problem, and it is ever changing. The scope of it is increasing by the day. New pathogens, new mutations. How many kits are you going to work with, right? So I think that is where our thesis is. PCR-based technologies, they are making diagnosis of assumptions faster, but they still have their limitations. Comprehensiveness of the test, the width of spectrum that you are able to cover, is going to be the perfect solution for the market. And that is where we think genomics as a technology is going to be the game changer. I think the world has understood the association of the analyte DNA with the advent of molecular that has happened in the last 20 years and last 5 years in India that ways. with the disease condition, with the infection per se. Now, taking it to the next level where we are able to use this understanding, but accelerate the coverage of pathogens that we are able to bring in, make the diagnostics kit independent. Don't need to test for dengue, don't need to test for E. coli. Test the sample to know what there is. That is the opportunity that genomics can unlock. And that is where we think new technologies is going to make a significant dent in how patient outcomes can be impacted positively. That's our view. And we also believe at scale, just like PCR, the cost of the technology came down significantly. Genomics is going to become a replacement of, or possibly at par with culture at the right scale. And that's where possibly 5 years hence, the world is going to be sitting at.
That's nice to hear you. Thank you so much. And I think the first thing I talked in the morning was PAGE, P-A-G-E. P was like personalization, A was advancement, and G was genomics, and E is excellence. I think all three together in diagnostic. Genomics has arrived. POCT is also arrived. With this, I think I'd like to thank you all, the panel. I'd like to sum up was saying that, change is the only constant when it comes in our field. And it's our ally. We must be agile, flexible, and guiding our team through the waves of change. That's very, very important. Help them around to navigate the uncharted territories. And this is where we're heading for. We don't know before COVID. There could be so many strains of COVID, and which strain would come further, we don't know. Finally, our North Star, actually, I'll say, must always be the patient. Everything what we do should be patient-centric, and every decision will be like helping the patient and, of course, better clinical outcomes. And today we stand on the platform of transformation. Let us, in this embrace journey with open minds. Let's talk about innovation. Let's be incubators. Let's collaborate together. Let us integrate. Let's adopt all technologies and learn from each other. Unless otherwise, technologies come and go because they're left in one corner. Somebody adopts, somebody's not aware. The awareness, everything is very, very important today, and integration is equally important. Together we can shape the future of diagnosis, navigate healthcare landscape with vision, courage, and relentless pursuit of excellence. That's a must. Thank you so much. Let the journey begin, and thank you so much for everybody. Thank you.
Thank you, panelists, for an insightful discussion. Thank you, Dr. Gaur, for your words and moderating the session. I would now request all of you to come forward for the felicitation ceremony, and I would like to request Dr. Gaur to felicitate his co-panelists. Dr. Naina Ingole. Mr. Bhaumik H. Trivedi. Mr. Bivas Chakrabarti. I would now like to request Ms. Pinky Cheher to felicitate Dr. Gaur. Dr. Ravi Gaur. I request everyone to please come together for a group picture.